Okay, good morning, everyone. Welcome to this second version, as far as I remember, of the complex upper limb surgery. We have today session on stiff elbow. We are very happy to have you all here with us today, and we have a lovely selection of cases lined up, submitted by people from all around the world. We will be allowing everyone in the next minute or so. And the course director, Dr. Kiran, and he's in Malawi at the moment, so he's having a little bit of connection issues. So I will do a brief presentation of our case discussants and faculties today. Mia, do you mind helping me with the slides?
They shared?
Yeah, so could you put the next slide? Okay, so this is the course agenda of this series of webinars. So the first one is happening now on stiff elbow. We hope to see you guys in the upcoming sessions. On the 7th of December, we have pediatric neglected elbow trauma. On October the 19th, on December the 19th, we have a gunshot and blast injuries of the upper limb, which will be the third and last of this year sessions. Next slide, please, Mia. A brief reminder about using Zoom. So you can click on show captions to follow the conversation if you want to change the language of the captions and make it friendlier for you as a users, because we have people joining us from all the world. So some of you, as you saw, also the pre-course classes are also available in French and Spanish in case you didn't have the chance to review them, but they are available on the Harper Global Orthopaedics Collaborative YouTube channel to be seen afterwards as well. If you want to engage in the conversation, feel free to use the raise hand function so we can call on you and make you participate of this session, or you can also type your questions in the chat or the Q&A, or using the Q&A facility. Okay, so next slide, Mia, please. The objectives are to share knowledge on stiff elbow in the other sessions in pediatric neglected trauma and gunshot and blast injuries of the upper limb, foster international discussion regarding this upper limb surgery and management of complications, and try to adapt that to the different settings where we work and the resources we have, and motivate and support younger generations of orthopedic surgeons practice in resource-limited settings around the world. Next slide, please. So the course chairs are Dr. Kiran Agarwal-Harding. He's with us today, solving some connection issues. He's at the moment in Malawi, and Dr. Duane Anderson. So we are grateful to have them both. Kiran does a tremendous effort and foster international collaboration through the Harvard Global Orthopaedics Collaborative. He works at Harvard Medical School in Boston. And Dr. Duane Anderson has been doing a huge amount of work and leading the certain approaches to conditions that are neglected elbow trauma in Soto, Ethiopia. Next slide, please. I will be moderating the course today. I'm Carlos Prada. I'm a hand, wrist, and elbow surgeon at Pontificia Universidad Católica de Chile in Santiago, Chile. Next slide. And this is a huge thank to all the Harvard Global Orthopaedics Collaborative and SONA organizing team. They do like a tremendous effort to make these sessions run smooth, putting all the conference lectures together and making this possible. So thanks to all of them, Alisa, well, Emily, Abduli, Marcela, Suhas, Joseph, Michael, and if anybody I'm missing, to say thank you for. We are enormously grateful for what you do. Next slide. Today we have case presenters from Malawi, Burkina Faso, Ethiopia. We have Damiano Chaula and Dr. Glory Sefu, both from Queen Elizabeth Central Hospital, Blantyre, Malawi. Dr. Malick Diallo from CHU Sorosanu and Burkina Faso. Next slide, please. We have Dr. Metasebia Worku Abebe from St. Paul Hospital in Ethiopia, Dr. Mohammed Naje from Authority of Al Tawra General Hospital in SONA, Yemen. Next slide. And our case discussants and faculty are Dr. Paolo Arrigoni from ASST Pini CTO Milan, Dr. Carl Harper from Beth Israel Deaconess Medical Center, Harper Medical School, Boston. Next slide. Dr. Roman Hayda from Rhode Island Hospital, Brown University, and Dr. Shoaib Javaid from the Hand and Upper Limb Center in Pakistan, in Lahore, Pakistan. So thank you, all of you, for being part of today's session. This is the agenda. After this brief introduction, we'll start and dive deeper into this session. We'll ask Dr. Damiano Chaula and Dr. Glory Sefu to please share the screen, and then we'll have a little bit of discussion on this case, and then we'll follow a second case by Dr. Malick Diallo, some time for the discussion. Then Dr. Abebe will be discussing case number 3, and if time allows, we will be discussing some additional backup cases we have. So thank you all for being here today. Please engage in the discussion, ask your questions, and let's make the most out of this session. Thanks. Glory, could you please share your screen now? Oh, I can see Dr. Kiran Agarwal-Harding now.
My connection's going.
Hi, Dr. Carlos. Could you please enable me to share?
Okay, let me see.
Carlos, if you just make Glory a co-host, that will do the trick.
Yeah. Trying to navigate that. So Glory, make a host. Okay, Glory, you might be now able to share your screen. We can see the slides very well. We cannot hear you yet.
Right. So the first case is going to be presented by my colleague, Damiano. Apologies, he was actually in theater. He's on call, so he's just scrubbed out. So I think if he is not yet ready, I'll just go on to present the second case, and he can join later on.
Fine, I'll present the first case. I'm available.
Okay.
So,
thanks, Damiano.
As introduced, I'm Dr. Damiano Chaula. I'm currently an orthopedic resident here at Queen's. I'm in my 3rd year of residency. So the first case that I'm going to present is that of a 23-year-old man who had a diagnosis of left distal interarticular humerus fracture. His date of injury was end of June this year. And the mechanism is that he was assaulted by thugs as he was walking home from his working place. So he was admitted on the next day. And then otherwise, his medical history is unremarkable. He didn't have any comorbidities. And the only remarkable thing was that he was a smoker. and also reported that he takes alcohol. Unable to quantify both the smoking, so couldn't quantify the pack years, and for the alcohol, he's a moderate drinker. Otherwise, prior to this, he had never had surgeries. So on physical exam at the time of admission, his ABCDs were unremarkable. They were all stable. On exposure, he had a swollen left elbow with discoloration on the cubital fossa, but otherwise no abrasions, no blisters, and no signs of it being an open fracture. And the distal neurovascular status was intact, so it was a normal distal neurovascular status. So at the time of presentation, we took samples for full blood count, did grouping and cross-match, and then did x-rays of the elbow, both AP and lateral, and then gave him analgesia to relieve his pain. And we also applied a bag and side slab and elevated the limb to help with the reduction of the swelling, and he was awaiting theater. So in the course of the wait, we noted that his blood pressure started rising. So he was then diagnosed with hypertension. So we're trying to optimize his newly diagnosed hypertension. And also because of unavailability of theater space, it took us longer to take him to theater. So the time we were taking him to theater, it was about 5 weeks post the injury. So these are the x-rays that we did on admission. As you can see on the AP, we can appreciate the left intra-articular humerus fracture, which is for the articular surface, we can see that it's a 2-block fracture, and on the diaphysis there is comminution. You can see little fragments over there, and on the lateral view, you can appreciate that the distal fragment is displaced posteriorly. So we then took him to theater, as I said, 5 weeks post-injury, because of the time we took to optimize his hypertension, and also because of unavailability of theater space, because of the overwhelming number of patients that we get mostly because of motorcycle accidents. Next slide. Next slide.
Okay, while we solve the issue with the slides, maybe some unstable connection at the moment. So, okay, so I would like to ask our faculties if, well, when you face, maybe it's not that, it's unusual sometimes for some to face like a 5-week-old distal humerus fracture. Do you have any special precautions, Dr. Harper and Dr. Hayda?
Oh, in terms of precautions, I've always been impressed. We see a fair number of these that present due to, people being afraid to present to the medical system due to socioeconomics and fear of sort of deportation, at least in Boston. And I'm always impressed at how mobile the metaphyseal junction is compared to the articular block. And so when I'm teaching the residents and fellows, when we think about having to perform our osteotomies, that's where I find the key is. It's getting that metaphyseal junction to align is usually easier because there's just so much force, but you really have to focus your attention on restoring the articular block, because that will often be sort of at that point in time relatively well healed and very challenging to restore.
Thanks, Carl.
I think the other thing to really think about is in those projections that we're seeing on X-ray, it's difficult to see how much involvement there is of the articular surface. What are the parts of the articular surface? And certainly if you've done a lot of these, it's much easier to figure it out on the fly. But if you haven't, it can be fairly complicated, particularly if they're really displaced to one another. You have partial union, and then to figure out what is going to be your best line of fit can be challenging. So, we know acutely that a traction film is really useful. In this case, I think it'll be of limited use. And in that kind of situation, perhaps a CAT scan could be useful if it is available. Obviously, that's not always possible, but then you're going to have to really scrutinize your plain films, maybe get some oblique views to really understand what you're getting yourself into. And there are cases where you may decide, depending on the patient age and other circumstance, that perhaps letting it heal where it is, or just restoring the metaphysis may be the best option. That takes a lot of thought and planning, but certainly those are on the table with these late presentations to at least do no harm.
Yeah, that makes a lot of sense. Thanks, Dr. Hayda. Damiano, you can keep going with the presentation.
All right. Before I proceed, Glory, can you project the immediate post-ops? So these are the X-rays that were done immediate post-ops. So as I said, we took him in 5 weeks after the injury. So intraoperatively, we did an olecranon osteotomy approach, and then used 2 plates which were placed orthogonal to each other. So you can see on one side, we used a 7-hod plate, and then the other one is an 8-hod plate. We tried, we started with the fixation of the articular surface. So we used lag screws to bring the articular surface together. And then once that was done, we then fixed the rest. Since we had it as a 1 block now, we fixed it to the metaphysis now. So these are, and then proceeded to do the tension band for the olecranon osteotomy. And then the time we were taking him to theater, as I said, he already had a stiff elbow, so he was only able to extend about 10 degrees, and then flexion was at 90 degrees. So immediately after surgery, we started air mobilization so that to help with at least having a functional range of motion at the elbow. So we saw him at 6 weeks. Unfortunately, I could not trace his X-rays at 6 weeks, but then I managed to get those that were done at 12 weeks. So the time we were living in clinic now, at least because of the physiotherapy, he had now at least attained a functional range of motion. His extension was between 10 to 20, and then his flexion was as good as up to 120. So the take home from this case is that as much as we can, we should try to take such patients early for operative management. As you have noted that if we delay already, it means the time we're taking them to theater, they will still have a stiff elbow, which is quite a challenge for the patient, because it means that elbow, they won't have a functional range of motion. And also always post-operatively, we should think of how are we going to rehabilitate such patients in order for them to at least have a functional range of motion at the elbow. Thank you.
Thank you, Damiano. Very interesting case. So you said, if I remember correctly, that the final range of motion of the patient was 10 to 120, or 10 to 20 in extension, 120. Okay, so maybe, well, to our faculties, anybody would like to maybe tell us what's the way you approach when you have a distal humerus fracture lately treated? Let's say in this same case, and we have like an 80 degrees like flexion extension arc with good pronosupination. First question is like, how would you manage like a delay subacute distal humerus fracture when you're doing your surgery, you already comment what you do different. But so, for example, do you change the way you manage the ulnar nerve if it is a subacute presentation? Would you transpose it? Would you do in situ decompression only? So, and if you have any clues for the audience on how you take that decision. And the other thing is like, how early do you move them? How is your approach for when the patients are stiff? Like how do you start trying to mobilize them, and if you use static or dynamic splinting, and when? So do any of you could give us some insights on that?
I have a couple of thoughts, if I may. First, the ulnar nerve management is the same. You have to isolate it and get it out of your field so you don't injure it in the course of reduction and fixation. And I'm of the thought, and this is supported by the literature, that there's no benefit to routine transposition. And so unless there's something in the cubital fossa that precludes that, I just leave it where it is. The second thing I think is really important, particularly in these delayed situations, the anatomy is a little more difficult. There may be some bone formation already. So your fixation, number one, well, first off, your reduction should be as ideal as you can make it. Second, your fixation should be strong enough that it will tolerate immediate motion. And my goal is to do that. Now, there are certain cases, this is more applies to the acute case, where there's such fragile bone or such degree of comminution that maybe to win the race of union versus non-union, I'll splint them for a longer period of time. This is like in severe open fractures, but that number of cases is extremely small. Usually you fix it so that you can move it right away. And yes, you may go slow initially just for patient comfort issues, but you should be able to fix it in such a way. The other thing is, once you fix it in the operating room, you check the range of motion. And it's impressive to me that even if you operate within a week or two, some of those patients are already stiff, even though everything else was done right. That just shows you how quickly the muscles and the other soft tissues can get contracted. But you check it on the table to make sure, number one, you're stable fixation. Number two, that there's no block to motion. Maybe you have a screw in a fossa. Maybe you have a malreduction, and you have to check that, and then that's going to be your standard to be able to follow them along in the postoperative period. Then
So
longer term, go ahead.
No, I think that maybe someone was unmuted, Dr. Hayda. You can.
Okay. So, and then in my course of rehab, I routinely get therapy engaged. And if they're not making progress at, 6 weeks, 8 weeks, then sometimes I'll use dynamic splinting. Usually I reserve any operative intervention till closer to the 3 to 6 month mark, so you know what the status of union is, and you can that the patient is in a situation where they can really focus on the motion of the elbow rather than union or other issues, and that's very individualized.
Perfect. Any of the other faculties want to add something to what Dr. Hayda said? I don't know if we have Dr. Arrigoni with us, or maybe.
Can I add something?
Yeah,
Hello.
definitely.
I'm Dr.
Hello.
Shoaib.
Hi, Shoaib. Good to see you.
Hi, how are you? Thank you. So, I live in the third world. I'm from Pakistan. So here we also get to see these late presentations. And we go on, fix them, but we try to follow in our center all the principles described by the Mayo Group, Dr. Sean O'Driscoll, the bicolumnar parallel plating and long screws. so that we could start them moving as soon as possible. Because as Professor said, that they're mostly already stiff. So if we keep them further in the slab, they get more stiff. So what we've seen is that the earlier we start moving them, the better we get the results. We have a lot of experience with these late presentations. So when and we try to avoid these screws outside the plate. We try to put every screw through the plate so that it's a stronger construct, and then we can start early range of motion. Thank you.
Thank you, Shoaib. That's very important, definitely. Like to try to follow the principles of distal humerus fractures as per Dr. Driscoll's principles that have been like obviously very good at quite a significant advancement in our treatment for these fractures. Would you mind commenting on how you manage? Because sometimes I think you might have some issues getting dynamic splinting yourself in your setting. And do you have any recommendations on the way that you treat non-operatively patients that are getting stiff?
So you mean the patients post-operatively when they get stiff?
Yeah.
That's what you mean? Yeah. Okay.
Yes.
So one thing I learned from Dr. Duane Anderson is in the low resource settings is to tell the patients to carry a bucket full of water as much as they can carry, so that they get these last bits of extension back. So that's helped me a lot in my practice, because people do not have access to formal physiotherapy in our situations. So carrying that bucket of water after 15, 20 days after the surgery helps them a lot. First, they carry the empty bucket, and then gradually they increase the amount of water in it. This helps me. And about gaining the flexion. So flexion, I usually start overhead in the overhead position, and we start it very early. I mean, after 5, 6 days, as soon as the patient is comfortable to go with it.
Okay, that's a very good tip, especially in resources where people need to go carry their own water, such as certain places, such as in Malawi, they need to go to get their everyday water in buckets. So I think it's a quite practical tip, Dr. Javaid. Thank you for that. Okay, we should follow the second case maybe with Dr. Glory Sefu, if you mind sharing with us the second case.
Happy to do that. Thank you very much. So I will take you through the second case, which is quite similar to my colleague's presentation, but this one is different in that it was an open fracture. So my case is of FK. He was a 54-year-old male, had a right open distal interarticular humerus fracture. So he was injured on the 29th of July this year. His mechanism of injury was that he was involved in a road traffic accident. So he was a passenger on a motorbike that was then hit by a fast-moving vehicle. So it happened in one of the districts surrounding the tertiary hospital where Damiano and I work. So he was referred to us a day later. Unfortunately, because they also tend to have limited resources, they weren't able to do the debridement. So he came to us with the open wound and the fracture. Of note, he had been newly diagnosed hypertensive while with us, but otherwise didn't have any other comorbidities. He's a non-smoker and a casual alcohol drinker, but didn't have any previous surgeries before. So on physical examination, ATLS, his primary survey, A, B, Cs, and Ds were clear, but on exposure, he was noted to have an edematous and tender right elbow with a 4 by 4 centimeter wound on the posterior aspect of his elbow. There was minimal contamination that was noted, and he wasn't actively bleeding, but he did have an intact distal neurovascular status. So the wound is as shown over there. So immediate management, he was given analgesia, antibiotics, a TTV vaccine, splinted with a back-induced lab while the rest of the investigations were being done. Had blood samples taken and x-rays, of course, and then was taken in for debridement on the night of his arrival. So these are the x-rays that you can see. So they were taken in the POP, but you can see the distal intra-articular humerus fracture, so affecting both of the columns. So was after the debridement, was then sent to the ward to await ORIF. So the things that delayed this patient in getting the definitive fixation is that there was need for soft tissue resolution. So as we talked about, was an open fracture. We wanted those soft tissues to settle. And as we said, he was also newly diagnosed hypertensive. So it took a while before we could optimize his blood pressure for him to be able to go to theater. Also, because of lack of theater space, our resources, our wards are usually quite overwhelmed. So it's difficult to take patients in when they need to be taken in because of the overflow that we do have. So between the debridement and the ORIF, there were 7 weeks that passed in between. So he was only taken into theater on the 9th of September. Because some time had also passed, because we said he was injured in 29 July, we did get repeat x-rays to see what the current status of the fracture was. So we had them taken out of POP. So you can see it was quite a comminuted distal humerus fracture with displacement at the medial condyle as well. There was a fragment that had started to heal in a rotated position. So those are some of the findings we had when we went in. Another thing that we noted intra-op was that there was a missing piece in the middle of the articular block. So it seems that was taken out during the time of the debridement. Unfortunately, this was not mentioned in the op note. So intra-op, we were now thinking of how to reconstruct this articular block and to give this patient as much possible motion as possible. So we did bicolumnar plating for this patient using 7-hole and 9-hole reconstructive plates. We did orthogonal plating as well. Starting with the restoration of the articular block, we tried to bring the two condyles as close as possible together to bridge the gap that was there between them. So there was a bit of compression at that site. But otherwise, we were able to then bring it back to the metaphyseal region. We had thought he might need some bone grafting as well, given the level of comminution that the patient had. So we did also consent for some iliac crest bone graft in case that would have been needed. But thankfully, we didn't need to do that intra-op. So as you had spoken of before, aiming to follow the O'Driscoll principles, we're aiming to have our screws interdigitating between the two plates on the different sides, as well as making sure that we have as much capturing of the distal fragments with our distal screws. We also did the olecranon osteotomy, so you can see the tension band construct as well, which was done. So also of note, sorry, I forgot to mention the soft tissues. When we were making our incision, we did have to curve it a bit more laterally than usual, given the state of the soft tissues, because it was all fibrous and scarred after the resolution of the healing. So those were some of the things that we had to think about in our approach. We ended up having to transpose the ulnar nerve posteriorly to the plate so that we could make sure that it wasn't going to be under tension by the end of the procedure. So he was then discharged after 5 days, had a good wound, everything was fine, and we followed him up 6 weeks later in our clinic. He was booked for physiotherapy, but our physiotherapy services are also quite overwhelmed. So we noted that when he came, he had only had one formal session of physiotherapy at the hospital, and his next session was booked another 8 weeks later. So he hadn't had enough physiotherapy training that he needed to have. And so this was the x-rays that he had in our clinic. So the bone fixation looks quite good, but of note, his function was still quite low. So preoperatively, sorry, I did forget to mention, he had a range of motion between 20 degrees inflection to 70 degrees, 20 degrees extension to 70 degrees inflection. But now 6 weeks post-op, he was at 5 degrees of extension and 90 degrees inflection. So there was a slight improvement, but he is still quite stiff. And so looking at the learning points from this case is that as we said, physiotherapy may not always be readily available for the patients. So sometimes I think as orthopedic surgeons, it's important for us to be in touch with physiotherapy and to get to know some of the exercises that they can have the patients do at home. So that even on discharge, we can counsel our patients on what to do so that we don't wait until they become very stiff and realize, oh, they're not getting the care that they need, but proactively telling them what they can do at home to limit the stiffness that they're going to have. Another thing possibly that we could have considered for this patient was probably application of an X-fix at the time of the debridement. So thinking of a way to, just provide the ligamentaxis, preventing contracture of the soft tissues, which was something that we also did struggle with intra-op. So essentially to span it, possibly have more imaging, CT imaging as well, for a peri or intra-articular fracture, scanning it, and then basically giving us a better plan for our intra-op management as well. So yeah, that's a summary of the case. Thank you.
Thank you, Glory. Would you mind telling us, like, so after the 6-week reviewing clinic with that range of motion, what were your, like, basically, did you discharge the patient or were you considering rehabbing them? I know the limitations of access sometimes to physiotherapy that is quite like evident and common in different scenarios and different countries. I would like just to know what you did with the patient yourself.
Okay, so he's still under our follow-up and care because we'll usually see them at 6 weeks and at 12 weeks. But then at the time we noticed that he was still very stiff, we did reach out to some of our colleagues in physiotherapy to ask them if they could bring him to a closer date, but also just have a teaching session because we know on their end they're quite overwhelmed as well. It's not possible for them to give him more dates per se, but at least just to tell them some of the things that they could do and to have them do it more proactively. Because some of them will wait until they see a physiotherapist before they start using the limb at all because they may be very afraid. Much as you tell them that, okay, we have fixed it, you can do some, active range of motion exercises, for example, to loosen it. But you would want the physiotherapist to be able to give them the guide and the control on how they're progressing. Because the other thing about it is in low and middle income settings such as ours, you often have patients needing to do a lot of heavy work, a lot of heavy lifting, manual labor and the like. So you'd want to err on the side of caution that they don't start doing too much too soon, but at the same time, making sure that they're not completely immobile and inactive. So I think we need a lot more patient education in that regard, which was what we did with this patient to let him know that he is allowed to move it, but it has to be progressive and controlled. So we sent him to physiotherapy that day just to, so they could touch base while he was waiting for the next formal physiotherapy review. And we're yet to see him in another 2 weeks in our clinic and see how he's progressing.
Perfect. Thank you. Dr. Hayda, Dr. Harper, Dr. Javaid, and Dr. Arrigoni, any of you have, let's say, any insight about, because we know that the stiff elbow can be treated non-op according to the evidence between up to 6 to 12 months after the trauma. So what's your experience with that, and how would you advise our audience today in terms of, like, do you think when is the time and what you consider to pull the trigger to go to basically capsular release or an open elbow contractor release? How do you work up yourself that? Like, do you encourage more the recovery of flexion? Are you more concerned about extension? What basically degree kind of cutoff points would you use, like the classical functional range of motion definition, or would you adapt that considering other factors?
I'll take a stab at it. I think timing-wise, it depends, for me at least, tremendously upon the presence of heterotopic bone. And somebody mentioned that in the chat as well. I think there's a fundamental difference between soft tissue contracture, which can be profound, as it was in this case, experienced intra-op, versus the rapid formation of heterotopic bone. So in the setting of heterotopic bone, I am much more inclined to operate early, i.e. within the first 3 to 4 months. I have found that you can get some degree of remodeling. And so I don't immediately go in when I see it. I tend to wait until the patient has clinically defined themselves. In the setting of purely stiff elbow with no heterotopic bone, I'm much more conservative, and I'm perfectly happy to wait at least 6 months. Although, and I think, Carlos, the literature you're probably referencing does show that after 6 months in the setting of a stiff elbow, the improvement is quite a bit less so than it is in the first 6 months. So I rarely at this point in time wait a full year. The longest I'll wait is 6 months. And then in terms of what I'm prioritizing, I think Dr. Hayda mentioned this at the very beginning. It's hugely individualized for me. I've got, patients who are purely administrative, who need that elbow extension to do, to reach out to type. And then I've got patients who are laborers who are able to use their shoulder and hips to position themselves, and they really need flexion. So that is a conversation that I have with each patient individually.
Thank you, Carl. That's quite helpful, I think. And any of the other faculties have any insights on this? How do you pull the trigger? Like, are you also quite aggressive with HO? Because the classical teaching was to wait until maturity, right? But we have seen like some changes in that trend and good results with early HO resections. So I don't know, what are your thoughts on that and your experience?
Yeah, I'd like to comment. We saw a lot of heterotopic bone in the elbow after wartime trauma. And at times we would see it as soon as, 2 or 3 weeks after injury. You're already seeing the formation of bone. Some of that's related to associated head injury and so forth. In any case, I total agreement with Dr. Harper that is as soon as it looks like it is mature, and classically that was defined as normal lab values, cold bone scan. That is garbage. It's really, you want to make sure that it looks like it's no longer forming new bone, and usually that's at 2 to 3 months. And my timing there is determined by if there are any other impediments to their continued recovery, and to assure that the fracture is also healing. And so, yes, at 2 to 3 months, if that's blocking their motion, particularly if it's bridging it, getting that out will make that patient a lot happier and be able to use that arm functionally. So that's really important. I think the other thing in this case I'd like to highlight, and this can be a complicated problem in the case of an open fracture, missing articular pieces, but it can also happen in severe comminution of the articular block. Yes, you want to get good contact between the remaining pieces, but if you do that, that will narrow the trochlea. And if you narrow the trochlea, no matter what you do with the soft tissues, no matter what you do with the heterotopic bone, you won't regain the motion. So it's really important to restore the relationship of the trochlea and the capitellum to maintain the width of that articular surface. And there are cases where, yeah, I'll take a tricortical piece of iliac crest to restore that so it's stable. It's not a normal articular surface, but restoring the width of the articular block is really important in retaining motion of the elbow.
Yeah, thanks for that tip. It's very important not to compress the articular surface if we don't have a restore width of it. I fully agree with that, because that anatomy impairment will create more damage than benefit. So there's a lot of questions in the chat. So maybe our faculties could enlighten us on this about primary and secondary HO prophylaxis. So what's your conduct? I know it's a controversial topic. What do you do in your practice, Dr. Javaid, Dr. Harper, Dr. Hayda, Dr. Arrigoni?
Hello.
Yes.
Can I add something?
Of course.
I'm Dr. Kattu from Pakistan. This was an open fracture, Damiano Anderson type 3A. We receive a lot of patients in our setup in daily routine. I would have treated this patient differently. As it was an open fracture, I would have taken this patient to the operation theater, did a wound debridement, and reduced the intra-articular block into one segment, and would have applied a Elizarov external fixator. That would be a better option, and we can start a range of motion from a very second day of a surgery. And we are doing routinely, and we are not facing any problems of elbow stiffness in these scenarios. This could be one of the options.
Thank you. So would you comment a little bit further about what's the construct of your Elizarov in order to allow for immediate range of motion?
Yes. I reduce these two intra-articular fragments with the two olive wires and apply a single half ring and two rings above these two half rings to stabilize the construct. And this works very nice, and this construct is very strong enough to hold the fracture at its place. With two full rings and one half ring. Half ring is applied at the level of the elbow.
Perfect. And you haven't encountered any difficulties in terms of like increased non-unions in your experience, or you have been quite satisfied with the rates of union of these fractures?
Definitely have some problems of a non-union. If we have a non-union later on, we can put a bone graft once the wound has been healed.
Okay, yeah, thank you for the comment. I think I don't have personally myself experience with Elizarovs for treating this in an acute setting. Having that said, obviously, leaving K-wires out for a little bit long in the setting of an open fracture, there might be. I don't think we have an evidence-based answer to answer that question, but probably I don't know what the rest of the faculty think. If they will be too concerned about putting K-wires and leaving them sticking out in the setting of an open fracture.
Yeah, even I do not have any experience with putting Elizarov in the elbows. It's very challenging. I guess, the nerves are there, and there's so much to be taken into consideration compared to tibia. I think it's a little dangerous in my hands, I would say. But about the heterotopic ossification in our setting, the people do not agree to another operation. In 3 months, like the other respectable faculty was saying that they're a little aggressive in going in at 3 to 6 months to, not waiting for it to get mature. But sometimes there are problems like patient do not agree on getting another operation in 3 or 4 months. So that is another problem that we face here.
Okay, thanks, Shoaib. Okay, we'll be moving forward to the other cases, so we have time to discuss other type of stiff elbow etiologies. So thank you, Gloria and Damiano, for presenting the case, and then we will be moving to the next case. Malick, I think would you mind sharing your screen?
Yes. Do you see my screen?
Yes, we can see it.
Okay, thank you. Thank you all. It's a pleasure for me to be invited to share my case in that conference. So this case is about, it's from Burkina Faso, somewhere in West Africa. It's about this young boy, around 12 years old, who sustained an injury of his left elbow when playing football. But as usual, they don't come directly in hospital. They take time before coming, doing massage and some traditional bone settings before coming to us in January 2024. And the elbow was very stuck in that position. You cannot bend it nor extend it. So the X-ray is here. We have a posterior dislocation and some ossifications. So I agree with family to go for surgery, and I choose to perform medial and lateral approach. So I removed a lot of scar tissues, and to be able to reduce the dislocated elbow. And after reducing the elbow, I face some instability. So I choose to do something different. I use a distal radius plate, and I bend it, and I use it as an internal fixation, as you see in this picture, and I put it in the medial side. And in the right side, you can see the operative, the range of motion with the plate. So it was I was worried for the skin closure, but I was able to close it well. So we started to do rehab after the operation, but he was not very compliant, and after 11 months he lost a lot of extension, but he kept some flexion. The hand was able to touch the face with the help of the shoulder. So this case is very frequent in our practice. There is a lot of surgical techniques, and we have some limitation in rehabilitations in our settings, and the outcome sometimes is not good. And for the elbow, it's the second location after shoulder. Usually it's around 10 to 15 years old, and a lot of people used to go to traditional bone setters before coming to us. So even when they come to us, it's difficult to make them understand the need for surgery, and sometimes they worry about the long time and the cost of long period of treatment, like rehab and things like that. For the surgery, usually we do open release, and after large open release to reduce the fracture, it's sometimes difficult to maintain a stable elbow. So in the last, we used to do pining, temporary pining, and for 3 to 4 weeks before starting rehab. And this time I choose to use this internal fixator because we don't have a hinge external fixator to allow patient to move after the surgery. And this is, I think, it's a good idea to help it's a good option. It's not very expensive, and it can help for maintaining the elbow function. And for rehabilitations, usually people it's better to get some motion machine. We don't have that. And we have also to get good OTs for exercises, strengthening, and lifestyle adjustment. Sometimes we have to do it in the clinics, and our clinics is like a OT clinics. So we just check the patient, and after that we take 5 to 10 minutes to do some kind of rehabilitation. It's we sometimes encourage patients to do things at home, because to get a regular appointment to the OTs is sometimes quite difficult, because they're living sometimes very far from the hospital, and this helps to reduce recurrence. And in my cases, it's very, I don't think it's a fair case, because we lost some motion after the surgery, and we were afraid of stiffness recurrence. And we have some another issue was the plate was after 3 months, the plate was just I removed the plate because it was under the skin and it was difficult to it was how can I say that, it was very uneasy for the patient for the plate, so I removed the plate after 3 months. And in one other cases, I get compartment syndrome after using it was bad complication we try to avoid. So this stuffed elbow is very common. We have to face surgery and rehabilitation challenge, and the use of this kind of internal fixation can help to help your patient and can ease the surgery and get better outcomes. Thank you.
Thank you, Malick. A very interesting case. I wanted to comment a couple of things. This brings us a little bit to last year's session on chronic elbow dislocation. So most of the things we have learned from chronic elbow dislocation comes from low middle income countries where, for different reasons, as you said, patients are seen sometimes with bone settlers, and then they come late they have a late presentation of a chronic elbow dislocation, which is a huge challenge. And I think if for the audience, like, there's a beautiful presentation on that, or on a technique of how to deal with chronic elbow dislocations by Dr. Duane Anderson that is in the Harper Global Orthopedic Collaborative channel on YouTube, with the technique and a step-by-step way to solve this complex problem. I think, sometimes I think the other very interesting concept is, like, there were some reports in the literature about this basically homemade or creatively made, as you did, internal joint stabilization systems, such as external temporary fixation with distal radius plates, as you did. I think it could be a very interesting or appealing solution when we have limited resources. Having that said, obviously, from what we learned last year, chronic elbow dislocation session, apparently using this sequential approach to chronic elbow dislocations, the persistent instability tends to be not that of a common problem. And in this case, you face it, and I think it was a good solution for the moment, but maybe soft tissue reattachments or repairs could have done the job as well. And I think also I was a little concerned about the persistent stability of the elbow in the post-op X-rays. I think it was not completely aligned, which sometimes can happen in these challenging surgeries and could be obviously a problem. I don't know about the faculty. Do any of you have any experience with chronic elbow dislocations, and what's your approach? What's your experience? Are they like quite unstable after you release these patients intraoperatively, and how do you tackle that instability if it happens to occur? I think Dr. Javaid had a case at least. Maybe Dr. Harper, you can feel free to comment on.
So one of the things that I always find fascinating in a chronic elbow dislocation is this like fibrous rind that forms around the distal humerus. And you truly have to, at least in the cases that I've done, use a 15 blade and peel it off. And when you do that, you then see bone, and then you can get reduction. It depends on, the severity of displacement in terms of your instability post-op. I live in a very resource unlimited environment. So I've got an IJS sitting on my shelf whenever I need it. And so, we tend to, when we treat these, favor early motion above all things. So even in a setting where there might be some slight subluxation that could probably be treated with splinting for 2 or 3 weeks, I will often put the IJS in to allow for immediate mobilization. But I would not say that with every chronic dislocation, I have found significant instability. often just the tone of the triceps and the biceps as they've contracted for so long is enough to provide inherent kind of implicit traction of the joint. So I would not say that every single time am I doing something to afford stability to the elbow in the chronic setting, but really peeling that rind off is, I think, essential, or at least anticipating having to peel it is essential.
Thank you.
Carlos, may I comment?
Of course.
I think finally I'm able to get some good internet connection here. So I actually did a case, not in a child, but in a 22-year-old guy just on Thursday. And I was, as Carl just very beautifully described, was peeling off all this rind from the bone, and it creates a very unstable elbow, as Malick just pointed out. And I have a very low threshold in these cases when I don't have an IJS of just transarticularly pinning the elbow and then casting them, because a stiff, stable elbow is obviously much more functional than a completely loose and painful and useless elbow. But in this case, actually, I followed Duane Anderson's advice from the conference last year. I drilled tunnels, little tunnels with a K-wire, at the lateral epicondyle, medial epicondyle, and then the epicondylar ridge. And I was lucky enough to have some number 5 Ethibond suture, very strong suture, and use that to close the soft tissue sleeves medially and laterally, and was really quite surprised by how stable the elbow became when I did that. Now, I ran the suture from the bone tunnels down along the sort of direction of where the LUCL would be, because in my case, the elbow was dislocated medially. In Malick's case, it looks like the elbow was dislocated laterally. And it looked like even after the IJS was placed, Malick, it seems you still had that dislocation, subluxation of the joint laterally. And I just wonder if maybe if you had added also the soft tissue repair, reconstruction, closing the sleeve around the elbow, if that would have helped confer additional stability to this. Because I was shocked, honestly, about how effective it was in the case that I just did.
Thank you, Kiran.
And Kiran, how careful were you after, like, after you felt that you repair the soft tissue sleeves medially and laterally and through these transosseous tunnels, and it became quite stable, as Dr. Anderson described in last year's conference and his series. How confident were you on moving the patient?
Not confident at all. Very, very nervous. So I put him into a splint, and he'll remain in a splint now. And I showed my post-op X-ray very proudly to Dr. Anderson, and his response to me was that I should have flexed him up more because I worry about him dislocating again posteriorly. So yeah, I mean, generally speaking, there's a question in the chat earlier. Generally speaking, in all my elbow surgeries, I splint them for about 2 weeks just for soft tissue rest. And then I will start the moving after that. I guess I'm more of a nervous surgeon that way. Although the one caveat I will give there is some thought about the dynamic stabilizers of the elbow. You know, like if you don't splint them and you allow them to start using the elbow, is there some role of the biceps and triceps firing and that creating that dynamic stability of the elbow? I mean, I think that that's probably true. I guess I don't trust my patients as much.
Yeah, I think that's a very important point. Like, depending on the patients we are treating and like their level of understanding of their injuries, the age, what we anticipate will be the compliance to the treatment. I think we have to be careful. Most of elbow surgeons will be quite, I guess, hesitant to move them right away if you're putting like either an elbow arthroplasty or something, or like a very complex distal humerus fracture. You will be protecting those soft tissue sleeves, avoiding seroma, avoiding like a problem with soft tissue coverage afterwards by having a wound days. And so I think most of us will be protecting them somewhat on the first 2 weeks. I would agree with that.
Carlos, just to finish up the point about the pinning in the cases, and I learned this, I think, really from Carl and from my other partner, Jack Wickstead. We discussed this last year. We transarticularly pin the elbow, and typically I bury the wires underneath the skin, and I drive them through all 4 cortices so that they're exiting through the posterior aspect of the humerus. So if they do break, I can extract them that way, and then I cast the patient. And typically I'll remove the wires at 4 weeks and then put them into some kind of removable splint or into a sling and allow them gentle passive range of motion. And that's sort of how I progressively improve the motion from there.
Thank you, Kiran, for that. I do believe that those transarticular pinning wires are quite helpful. Sometimes we are a little hesitant in certain scenarios, such as open fractures or like soft tissue defects concomitant with the injury. When you do them, what size of wire do you use?
At least 2.0 millimeters. Yeah, it has to be something stout.
Yeah, for persistent stability, other than this creative solution of Malick, of like a distal radius fracture bent in a way that tried to mimic an internal joints stabilization system, that's one option. X-fix sometimes is available, sometimes it's not available. But I also wanted to comment another option when you have persistent stability, and if you plan to stage maybe, and you anticipate your patient being stiff, but you want to concentrically reduce an elbow that is stiff, and you're not able to basically achieve stability inside intraoperatively, you can also put like a bridge plate. It's also described, works quite well. I don't know if any of you have some experience. I was trained in Western University under Dr. King's, which is a good and experienced elbow surgeon, and in a couple of handful cases of persistent stability after either an acute elbow bad fracture dislocation, that could be, or maybe if you're releasing a chronic elbow dislocation, you can use a DCP plate, a long one, put it on the humerus and on the ulna, and achieve some stability. And then eventually, obviously, it's a two-stage surgery where you will have to remove it afterwards, of course.
Yeah, I think that's much safer than the K-wires and the casts. And Chai Mudgal, who was one of our lecturers last year, advocates for that, putting on a plate. The one thing I'd say about that is I've also done that, and I've also failed doing that because I bend the plate too acutely. And if you bend the plate right at a screw hole, then all of that stress is going through that screw hole, it'll break. So please don't make my mistake.
Thanks for sharing that. We all learn from our prior mistakes, and it's quite helpful. Yeah, there's some questions about how difficult it is to conjure and bend the DCP plate, to contour the DCP plate. It's not that easy, but it's doable. You need to try to avoid the stress riser and bend it in up to 90 degrees, no more than that. Somebody in the chat is asking about that. And there's also like a beautiful like in the elbow of book of the Brian Murray, in the last edition, there's a chapter on this technique for those who are interested in having a look at it and having it as one more tool in your armamentarium. Okay, so anybody of the faculties want to say something else about this chronic elbow dislocation case? Or if not, we might move to the next case of Dr. Abebe.
So can I add something?
Yeah, of course, Shoaib.
The cases that I've done, the chronic elbow dislocations, I have some experience. I've done 4 or 5 of these. What I've noticed is that if we reattach the ligaments with these drill holes and we flex it beyond 90, we keep the patient in flexion beyond 90, and then we can start moving the patient on 2nd or 3rd day. It's very easy. It's safe arc of motion. You take his arm above the head while he's lying. He takes his arm above anti-gravity and he starts moving into flexion from 90 to 120, 130, 140, wherever he can take, but not going below 90. not trying to extend early on. And then gradually after 3 to 4 weeks, you can allow them to extend. It's a very powerful construct. Those who have done it, they must be knowing it. It's a very powerful construct if we attach it through the bone. Transosseously, we attach the anterior and the posterior flaps. The elbow gets very stable, but we, of course, have to take care of not allowing them to extend it early on with the fear of redislocating. But the technique that Dr. Duane has explained, I mean, it's an excellent technique. I used to do it by cutting the triceps before that. And once I started doing it with this technique, medial and lateral dual approach, the outcome became excellent. The patients are very happy usually after 3 to 4 months.
Thank you,
Thank you.
Shoaib. Maybe Dr. Anderson. I think I saw him. I can see him on one of the screens. So, do you mind adding something, Dr. Anderson? You have a lot of experience in most of what we have learned. We have learned from you and Dr. O'Driscoll with your experience in chronic elbow dislocations. You are muted, apparently, Dr. Anderson. Yeah.
Let me apologize first. I plugged in my phone and set my alarm, and I just woke up a few minutes ago. So my apologies. My intent was to be on time. My phone cable I'm obviously going to have to replace. I've had been fortunate to have mostly successes, although I did share a paper where I shared my failures. And I think the biggest problem with the technique that we've described is not concentrically reducing it. And that will lead to instant instability if you are not, if you're going to go from there. So what that means is you have to really make sure that on the table that the ulna is completely reduced into the cavity that that to the roundness of the distal humerus. And if that doesn't happen, and you will, even if you pin it, it may not work. And so usually it's the scar at the very bottom of the olecranon fossa. It's right there, scar that goes transversely across that space. That prevents a full reduction. If your bony anatomy is normal, as our other author said, you can start early motion. And we never did this overhead thing. We just made sure they were in a sling. And the sling that you have in the developing world is much better than what you have in the developed world, because you can just slide out of the sling in the developing world. But if you tie this little sling around the wrist, it's not going to go up. And you hold the elbow above 90 degrees and you work on motion right there. And then usually starting at 3 days, and then after that, after 10 days or 2 weeks, then you can start letting them extend. So that's my advice, is to make sure that your reduction is concentric at the time of the table. Check after you've repaired it to check for instability. If you have a very young child or an alcoholic, your sling is not going to work. So either pin it, cast it, or whatever. But if you have a reliable patient and you have a stable construct on the table, a simple sling, in my opinion, is adequate. Thank you.
Dr. Anderson, have you encountered the need to do something to the triceps, like a triceps fractional lengthening or something in one of the more in the chronic cases? And would you tell us, like, if you change, or what's your management of the ulnar nerve in the cases as well?
First question is, I use an 18 gauge needle and go right through the skin and the triceps while I am maintaining gentle pressure. You can, if you have an overzealous resident, I mean, you can just crush the distal humerus. So the triceps is your friend until it's not, meaning that you can overpower, you're stronger than that distal humerus if it's a chronic elbow. And so you have to kind of balance walking a 10 centimeter beam, if you will, and carefully try to get the elbow to 90 degrees. If you can't get the elbow to 90 degrees with gentle pressure, then you have to fractionally lengthen it, barbotage, whatever you want to call it. And I use an 18 gauge needle. Go all the way through the tendon, up and down. Now I've never seen a triceps avulsion or a rupture with that technique, but I think the goal is to get above 90. If you can't, then I think you have to pin it or you have to cast it or whatever. Your second question was what? Again, I forgot.
About the ulnar nerve.
Yeah, the ulnar nerve in our video and in our paper is described as either placing it anterior to the joint, which is my preference, or putting it subcutaneously anteriorly. If you don't, if you think, well, this is going to be fine, you are going to have some unhappy patients because it's short. I mean, it might, if it's a month old, you might get by, but I'm sorry. You are going to destroy a patient's life by keeping it posterior. You got to get it anterior. I've never had a problem putting it in the joint. Distal doesn't like that, and so I tried putting it subcutaneously for a while. I just don't like it as well. You're creating another flap. I think there's more danger in entrapping it when you put it subcutaneously. That's just my preference. And I cannot say it strongly because, you know, Driscoll's a very bright guy. And if you too strongly disagree with him, you're probably going to be wrong. So do what you feel doing best, but make sure you get it anterior and make sure that ulnar nerve is happy.
Duane, when you say put it in the joint, I think you're basically referring to put it like up against the joint, but submuscular transposition, right? Like you're repairing the anterior sleeve. Yeah.
Yeah, there's I don't know how to share my screen quickly, but
we have, I think, your videos and everything from last year with a great demonstration of that. But it's basically when you're repairing the common flexor pronator or WAD to the medial epicondyle through those drill tunnels, the nerve is underneath. It's a submuscular transposition of the nerve.
It's submuscular, and basically it's laying on the anterior humerus.
Yeah.
If you will, it's coming out of that intermuscular septum proximally, following the anterior humerus until after the elbow joint, and then exits the repair there. So you can entrap it at either end.
Yeah. I mean, in the case, like I just worry if I have to come back to the same case, you know, finding the nerve, if it's underneath all the muscle, would just make me nervous, especially if it's full of scar again. So that's why I put it subcutaneously, you know.
I think you have the same problem subcutaneously. Bottom
probably.
line is, if you go proximally enough, you're going to find it.
Yeah, that's true.
You do not want to go in the area of your surgery. You want to go you know, if you need to go back, you need to go proximal and find the nerve. And if you don't, I think you're in big trouble. Obviously, we all know
that. Before Carl leaves, oh, and he's gone. Never mind. Maybe I could just ask one last question as Meti gets her slides up for Malick. You know, and to the rest of the group, Malick, you chose to use this distal radius plate as sort of an internal joint stabilization system. Very creative, and I really applaud your use of creativity there to do that. Does anybody else do that to sort of give some additional stability to the elbow to allow early motion, other than the methods that we've just described? No. All right. I think maybe, go ahead. Sorry.
Yeah, sorry. So yeah, we also use it here in Pakistan. We used it on many patients, and you know, the elbow gets quite stable, but still it has, you know, another implant that needs to be removed at 3 months or something. So I don't like it though. So I would stick to this transosseous repair and you know, and trust on it.
Thanks, Shoaib. And thanks, Malick, for a really fascinating case. Congratulations.
Yeah, thank you, Mom. So, Mita, please go on.
Thank you. I hope you can see my screen. Carlos,
yeah, we can
you?
see.
Oh,
yeah, we
okay.
can see. Go for it.
Okay. My name is Metasebia Worku Abebe. I'm a plastic surgeon from Addis Ababa, Ethiopia. So it's going to be a bit of a different presentation than the rest of the group, as I am from plastics and not from orthopedics. So don't be expecting any plates on my pictures. So I'm going to be talking about post-burn contractures. So burn injuries, just to give you a background, globally about 9 million burns required medical care in 2019. And when it comes to the Ethiopian context itself, we have had 700,000 per year. We are a population of 120 million, but we had about 700,000 per year burns, and that comes to 9% of all our injuries. And what makes it unique in our country is the typical open fire cooking of our society. So this is how food is prepared in majority of the society. And so it's an open fire cooking type of tradition that we have. And that's why it's a risk factor for burn injuries for the pediatric patients who will be hanging out with their moms and the mothers who are cooking for the family. So just to give you a context of the commonest causes of burns in our country, in the pediatric population, it's the scalp burns. As I've said, we have an open cooking type of tradition, and the kids will be crawling into the open fire and also trying to pull on plugs of water heaters and so on. So scald injuries are common, and also spilling their milk and so on. So scald is common for our pediatric patients, and flame burns are the commonest injuries in our female population. This is mainly because of the open fire cooking tradition, and also we have a large amount of patients who are untreated epilepsy, where they end up seizing, and post-ictal. The post-ictal period is spent on the open fire, where they end up with a very deep burn. And in the adult males, it's the epidemiology is now shifting into electric burns because of the construction and industrialization going on in our country, and the absence of regulation ends up in them having no protective equipment on them, and they end up with a burn. So just to share a few cases with you, the first one is a 45-year-old female patient who sustained a flame burn 6 months back. She was admitted in our burn unit. She had extensive burns, and some of the wounds were grafted and some were not able to be grafted because of the extensive burn she had. And the list of problems were she had a lip eversion, as you can see. She had an incontinent lip, I would say. When she was taking fluids, it was dripping over. And she also had elbow contracture and hand contracture. As you can see in the picture, you can see her right elbow is contracted. She has almost a 90-degree flexion. And you can see the hand as well, which has a dorsal contracture. It's an intrinsic minus position. You can see the MP is hyperextended and the PIPs are flexed. So her elbow was the right elbow. It was in full flexion. At least she was able to have a full flexion on her elbow, but the extension is limited. She can only extend up to the 90 degrees. She has a broad hypopigmented scar contracture, as you can see here. The hypopigmentation is on the lateral part, but she has a whole scar over the forearm and arm. So when we come to the management, contractures, the contracture release principle is to go from proximal to distal, because in a contracted shoulder or in a contracted elbow, if you end up releasing the hand, they're not going to reach and be able to feed themselves or use the hand effectively. So you go from proximal to distal. So we have released the elbow scar, and you need a supple tissue, be it an advancement flap, a rotational flap, or a full thickness graft to cover your area of elbow flexion, which is a high mobility area. So this is what we did for her. So she was released and skin graft was done. So it was a thick spread thickness because we didn't have that much of a donor site in this patient, but she was able to get a full extension on the elbow, and we splinted her actually because the skin graft needs time to heal. So she was splinted in extension, and full range of motion exercise was started in about 2 weeks' time. And we also released the lip. This is an Islander flap for those from plastics. And then we were able to fully release and give her a continent mouth. This was a patient post-operatively. And we have a few cases, so I'll be taking the questions later on. So I'll discuss a second case. It was a 30-year-old male patient with a flame burn. He was skin grafted at the time of admission, and over a few months, he presented with a dense scar over the lateral side of the arm, proximal forearm, with elbow contraction and scar over the dorsum of the hand. You can see him here. The medial aspect is actually okay, but you can see the elbow contracture, and you can see the whole grafted area and the scar which has caused the contracture in this patient. You can see also the very thick scar over the dorsum of the hand. So release was done for this patient. We were able to attain a full extension in this patient and use advanced medial skin, but we had a superficial wound, but he was able to recover from all of that, secondary heal from all of that, and maintain his extension. So this was him. And the third patient is a 12-year-old female patient. Again, as I've told you, our patients usually present with an untreated epilepsy, and they lose consciousness on an open fire cooking practice, and they sustain a very deep burn since they're in a post-ectal state and unconscious and sleep, unconscious on the fire. They end up with a very deep burn. So she had also a high ulnar nerve palsy, where she was able to sense her ulnar side, and there was no FCU or FDP of the lateral two fingers. The ulnar two fingers was lost as well in this patient, as you can see, and the elbow is exposed. She has an extensive wound spanning from the arm to the forearm. She had some skin left on the lateral arm. So what we did for this patient was actually, my colleague was the one who did it. We needed to stabilize the elbow as it was debrided, as the exposed bone was debrided, and we used the lateral tissue for a lateral arm flap, which was based on the posterior collateral pedicle, and the elbow was covered, and she was discharged with an X-fix. We have seen this patient over the last 1 week, and she still has some stiffness in the elbow and is on physiotherapy, but we were able to fully cover the wound for this patient, and she's on follow-up with us. So this is the medial aspect of it, where we have grafted her, and these are the cases I'm sharing with you. Thank you.
Thank you, Mita, for those interesting and wonderful cases. Are obviously another source of elbow stiffness, like when we have a contracture after a burn. Do you have any experience with like electrical burns, and were you successful in achieving the motion just by releasing the soft, like the skin and subcutaneous tissue, but putting skin graft, or did you have to do anything to some of the tendons to be able, like the biceps tendon or like some sort of lengthening to achieve that extension? Or did you encounter any difficulties, or would you guide us through that?
Yes, the electrical burns are quite different from this deep flame burns and the ones we have shared here. So what happens in the electrical burns is it's a full thickness burn. It goes through the body. It affects the muscles. It affects the bones as well. So since the bones are the high resistance tissue, the muscle is immediately the one which is next to the bone, and it gets to be burnt as well. So they will have a muscle contracture as well. So in this patient, you usually cannot achieve maximum range of motion with just a soft tissue release. So we do manipulation under anesthesia for these patients as much as we can early in the post-burn period, so that we are able to at least release the muscle in these patients. But it's not as straightforward as those with skin contracture or those with a flame burn, because it's very different for them. They end up with a very contracted muscle as well. So the range of motion we try to manipulate under anesthesia early, but it's very difficult in the electrical burn patients, because they also have this neurologic sequelae with spasm and spasticity and so on. So it's different for the electrical burns, and they need earlier intervention.
Okay, and I have a question for you, and maybe for some of the faculty which have encountered some ankylosed elbow from different origins. When you release them, do you have concerns with the vascular, like the brachial artery and the median nerve being neuropraxic when they have been contracted in flexion, for example, for a long time? Do you have any specific advice for us and the audience about that?
Yes. So whenever the contracture is prolonged, the vessels, as well, the neurovascular structures in general tend to shorten as well. So it's good to have to expose these neurovascular structures and have them in your visual field as you try to extend this when you're trying to manipulate the elbow or whatever joint you're manipulating, because usually they tend to shorten, and you might need to do it in a staged manner instead of just doing a full extension in one go. Sometimes because in a very prolonged contractures, they tend to have this shortening of the neurovascular structure. So when you're in doubt, then, or when it's prolonged, it's good to have them in your visual field so that you know what you're manipulating and how much your neurovascular structures can get stretched. You might need to just stop and do it in a different setting once you have achieved a maximum extension with your operation as well.
So Mita, a little bit further on that. I know Kiran has a question or wants to comment about it, but before that, I want you, so you basically expose the brachial artery, the median nerve, and you have them on your view and see how they behave when you're releasing. That's how you do it?
Yes, you'd see, you don't want to make it under maximum tension. You don't want the vessels to spasm. You don't want to, disrupt the epineurium of your nerves as well. So you don't want to go beyond what it can tolerate. So you do the maximum soft tissue release and try to extend. And if your nerve is too stretched, your vessels are being, the outer coverage of your neurovascular structure is getting too stretched, then you stop, you close, you splint, you do physiotherapy, come back, and then extend. You sort of stage your intervention instead of just going maximally and compromising your neurovascular structures.
Thank you, Mita. Kiran, do you want to comment something on apparently, or?
Yeah, I think actually Meti answered most of the stuff that I was going to ask already, which is why I put my hand down. But I think the one question I have is about timing. Meti, it seems to me that if you're doing like a really extensive soft tissue release, including like capsule and stuff like that, I mean, if you wait too long, you're going to have to do that, right? So do you try to do these a little earlier so that the elbow still has some inherent flexibility to it and it's just the skin that you're trying to release? But then how do you balance that with the continued destruction and injury that has occurred at the time of the actual burn? I'm just curious how you balance those two things.
Yeah, it's always a dilemma when it comes to these cases because as we have discussed, the capsule, the ligaments are contracting while you're waiting for your scar to mature. But if you don't wait for your scar to mature and stabilize as well, you won't have a soft tissue coverage once you release and you have the maximal function in your joints. So it's balancing between the two. And soft tissue coverage is absolutely necessary. Even if you release maximally and you have a good range of motion without open wound, then you're going to have another contracture definitely on that joint. So it's about balancing motion and also healing in this patient. So it's usually a tricky situation in these patients, but we try to maximize function, but we also try to respect the tissue healing as well. So I wouldn't put a timeline on this, but we try to balance between the two. Yeah.
Thank you. I think it's very, very important to keep it in our minds. Maybe we don't have clear guidelines for this yet, but I think as long as we keep it in our minds and we're not too aggressive on it, we might not disrupt the structures. Do any of the faculty have any experience with this? Like you have been releasing an ankylosed elbow or a chronic, very bad dislocated elbow, and then just by reaching out, complete range of motion in post-op, then you have like a vascular like complication intraoperatively? Or do you have any recommendations about like, do you release routinely like the pronator, for example, for the median nerve to be a little bit more happy? What are your thoughts on that, Dr. Javaid, Dr. Hayda, Dr. Anderson? Do you have any recommendations or any thoughts on that?
I think that a basic principle that we all need to remember is, when you're doing these procedures, being aware of what are the structures that could be compromised and checking intraoperatively on their function and immediately postoperatively is really important. Fortunately, I've never had a problem where there was a neurovascular compromise following the surgery. But that doesn't obviate the fact that I still check every time, particularly the longer standing, the more complicated, the more deformed that you're dealing with, the more likelihood there is of such a thing happening.
Thanks, Dr. Hayda.
The only time that we've had a vascular injury and a chronic elbow dislocation is with a visiting surgeon who was confused by the anatomy and went way too anterior. And so I think especially when you're beginning this, the anatomy is really distorted, and slow down until you know where you're at is my advice. I don't have any experience with the burns.
Yeah, I can add something to that. I think that will be useful to everyone. And this is probably just a general principle, but whenever doing any kind of revision, the presence of scar is very real. And it is, particularly with like the ulnar nerve, it's encased in scar. You don't know what's the nerve and what's just scar. And so the principle that I was taught, and I still follow, is to go to an uninjured area, start there, and then dissect into the zone of injury, because otherwise there's no way you're going to avoid injury to it.
Yeah, I think that's critical. I think we forgot to mention that kind of like a basic principle, but it's like completely like a game changer to go through an injured area where we are dealing with this kind of complex cases. Yeah, thank you, Dr. Hayda, for highlighting that. Well, I think we're a little bit running out of time. So maybe I wanted to ask the faculties a couple of things about how do you treat your stiff elbows? Let's say patients that have a non-functional range of motion, they are 6 or 12 months out of it. In terms of surgical treatment, what approach do you use? Like surgical approach?
For my stiff elbows, in the past, I would approach them the same way that I approached them at the beginning if it was a post-operative complication, either posterior or lateral approach. But now I'm learning from Sean O'Driscoll that he actually will approach them medially and laterally. But Carlos, do you mind if we just jump to Mohammed's case just so that we can cover it? Because I do worry that, it's such a great case and has so much to learn there that it'd be great for us to hit it before the end of the 2 hours.
Perfect. So Mohammed, do you mind sharing your screen, please?
Or should you give me a request?
You should be able now, apparently, to share.
It's appear? Is it appearing? That's
Yes,
okay.
we can.
First of all, I'll start with my case about complex elbow injury in the Yemen Taiz. As you know, Yemen is the developing country, and it's so the resource, the instrument is very little, or this is a case as a crushed elbow. History: this is a man, 22 years old male patient. Post-motor cycle crushed the injury, the trunk rolling on his arm, the right arm on his elbow, complaint of bleeding and deformity in the right elbow. The general examination of the patient. Patient was Glasgow Coma score is 15/15, conscious, oriented, stable vital signs. The blood pressure was 100/70. Pulse was 100. Respiratory rate was 20. Temperature within normal, 37.5. Head and neck examination, there was abrasion on the right side of the cheek, and also no other abnormalities found either in the chest or in the abdomen. Local examination. Local examination from, this is a right arm. This is right arm and forearm, elbow. The soft tissue, the skin was loose, loose and crushed from the upper anterior lateral aspect of the arm up to the anterior medial aspect of the forearm. A muscle was crushed around the elbow. Also, a nerve was partially injured radial and ulnar, but partially vascular, intact but weak, and was spasmed from the first. Ligament was injury, medial and collateral ligament. Bone was, this is photos on the operation theater because we cannot get examination on the ER. So we do for him examination. This is an open fracture 3B. The humerus was segmental fracture, and there is a segmental loss of the distal humerus. Also olecranon, partial loss of olecranon process, and also radius head is comminuted fracture with bony loss. In emergency room, we do for him as principles ATLS and ABCD. Primary survey was done and secondary survey, and we do for him prophylaxis antibiotics, cefazolin, gentamicin, metronidazole, and X-ray, and then transfer to the operation room. But there is a multiple challenge because, as you know, we are in the Taiz city. If you know, or if you listen about it, Taiz city is in the center of the Yemen, and it's also closed. And it's the opening to enter Taiz in 6 a.m. and to close 6 p.m. And the patient was in the 5 p.m. before the closure. And we don't have a plastic surgeon attend. We don't have a vascular surgeon. We don't have orthopedic instrument at the time. We don't have a neurosurgeon attend. Very poor patient, no CT scan, bad situation. We cannot do just this. And the patient came to us, referred from other hospitals. They said for him, they will do amputation for him. So that we decide to go after we get a consent from the patient and we explain all of things from the patient and relative about the stiffness, about suspicion of the amputation, about the vascular, about the compartments, everything. And we go to the operation room. We do for him first irrigation by normal saline, about 4 liters, and then strap and scrub again and do debridement for the impaired ligament and also the muscles, and also redebridement and rewashing irrigation by salines, and the reposition of the elbow dislocation. We try to do reposition of the elbow dislocation in 19-degree position, and the fragment reposition and fixation, and try to do covering, and we try to do covering as we can from the soft tissue to cover the bone and to cover the ligament there. Also, we do for him fixation about from the segment to the humerus and from the olecranon. And also we do for him external fixation, 2 roots in the anterior lateral of the proximal humerus and 2 roots in the ulnar. And we do for him fasciotomy, subcutaneous fasciotomy from forearm. The pulse was at that time when we put the external fixation in more flexion, it was disappear, and we recheck the pulse. The pulse was spasm. We reposition in the 19-degree and we give the patient heparin at the time, and we try to approximate the skin, not for skin, but for the underlying tissue because it's white tissue and also the nerve and the capsules. We try just to make it as a temporary biological covering. Then after that, so we do from the patient follow-up. This is the picture in the 4th day. And after that, the skin will become black more and more. We do debridement multiple times in the OT, on the operation room. And we do dressing. And we are concerned about the subcutaneous. We remove the dead tissue only every time. And when we monitor the patient, also we get a culture when at the 4th week, it was a staph, and we give him antibiotic due to the culture. And we do multiple plastic surgeon. We get his consultation more than time. He refused to do for him because he's from out the city. We go and I go to other city for this case to consult about what can we do for him. The patient is a young and his right hand. After 6 weeks, the plastic surgeon accept to do for him skin graft. After that, we do at the time we do dressing and remove a QIR before it 1 week, and he do his skin graft partial thickness. We get a conversation with him if we can put full thickness graft in the elbow, but he said he will do the primary skin graft and the second stage will do We remove the external fixation at about 9 weeks. We try to do physiotherapy and mobilization under general anesthesia in the operation room. As you see, this is the flexion and this is the extension. After that, we monitor the patient. This is the patient. After about 10 up to 11 weeks, he can get his right-handed to his mouth and also to his head, and can close his bottom shirt, and also can flex and extend his wrist. As you said, this is an X-ray. This is immediately post-operation. Also, at the operation time, we don't have C-arm even. Just we put the X-fix like this, and this is after we remove the key wires, and this is one skin graft. The summary of the case is 22 years old male patient, complex elbow injury, done debridement and external fixation, skin approximation and necrosis, multiple dressing and debridement, then skin graft with stiff elbow. Now he is in the physiotherapy. Our plan, and we would like to listen from you if you have any advice to us. We do for him, we send him for rehabilitation and physiotherapy. Can we do for also, we are thinking about to do for him elbow reconstructive, Z-plasty, full thickness graft. This is, we are get conversation with the plastic surgeon if he do for him. Also, can the patient do arthroplasty? But very poor patient cannot move any places. Also, the operation was relatively free, and he don't have his very poor. We are on the follow-up. We are thinking about to give him a dynamic splint, dynamic brace, and he's young. This is what makes us good luck for us and him. He is a young and he's able. He'd like to do to move his hand. Sorry, previously also we do resection about the head of the radius, and we check the pronation and supination at the time of the operation. This is the photo, as you said. This is in the admission. And this is the operation. This is also the nerves. And this is at the operation. This is after operation, 5 days. And this is multiple debridement and multiple dressing. And this is the last photo before 5 days. This is our case. I hope to listen from you if you advise us to do for him anything if we can help. And thank you for all.
Thank you, Mohammed. Quite a challenging case. So obviously, especially considering the limited resources that the patient had, the complexity of the injury, the lack of even imagenological studies sometimes to take for the decision making. I think that what Dr. Kiran said before about first getting a concentric and stable elbow and then maybe dealing afterward with the stiffness is crucial in this case. So immobilize the patient, achieve good reduction, soft tissue coverage, I think was obviously the smartest thing to do here in order to save that elbow. Yeah, very, very challenging. And I would comment on elbow arthroplasty for such a young patient. Maybe it's not, well, I think he doesn't have the resources either to do it, but I think I would be highly careful. I think we normally don't try to put an elbow arthroplasty in such a young patient. I think it could be more of a detrimental solution that a benefit from him, considering this such a young age and that he will undergo several procedures very likely during his life. That elbow arthroplasty won't last him his lifetime. So yeah, that's my only comment on that as well. Anybody from the faculties would like to add something?
I would like to add something. I commend you, Dr. Naje, for this case, and it emphasizes a couple of things that are critically important that are often not done. You see the picture of the trauma and you say nothing is possible, and you don't really know what is possible until you go into the operating theater and really assess what you have. Now, an exception would be is if the patient would be in extremis, where you can't do anything complicated, then you may just need to do the immediate amputation. But as long as a patient is stable, then really assessing What is the bony injury? What is the articular injury? What is the status of the nerves? What is the status of the muscles in an orderly fashion? Then tells you what kind of reconstructive or salvage options are possible. And the debridement allows you for a good assessment for that. This wound was widely open. It's harder when the wound is small and the fracture complex, but you know that it is very dirty and people don't want to extend that incision. That's when it's critical to really extend it to really see what's going on. And you extend it in such a way that you can use it for your later reconstruction. So the debridement and the assessment was the key two parts that you did at the start that set everything else up. And I would say, and I totally agree with you, Carlo, is this result is excellent. Arthroplasty will make him worse, and it doesn't have the longevity. And he may get more flexion. You could debate, his flexion is adequate. You might get 10 or 20 more degrees if you did an open release, but you have to question yourself whether that's worth the trouble. And probably not. It'd probably cause more harm than good. You got a good reduction of the articular surface. He's functional. Getting more could be seen as greedy.
Thank you.
But I commend you.
Thank you. We try to do our best from him because no instrument, even if just we have key wires and X-fix, there is it. But we try to do, as Prof. you said, we do for him debridement. I will try to save a limb as we can. And I think the patient is also lucky because now he's about 10 weeks and he's a beater and he can flex a little bit and extend and he can get some water bottom. And we try now to do for him dynamic brace. I think it could help. Also, it's very poor. He cannot do anything, just not either arthroplasty, just we are saying, but I'm sure he don't have any money to do anything. Just he came to us and he was, even if his relative said for us just imputation, it's imputation, we don't do imputation at all. But the relative said for us, yeah, it's a complex, and we said we'll try to do our best. And the result, I think it's accepted for us as our community. So that I tried now for just physiotherapy, and we try. I think he will be better. Thank you for all.
Thank you, Dr. Naje. Very, very interesting case. I think that maybe we can put the slides again, Emily, if it's possible to share some closing thoughts of the session, unless someone wants to say something about it. I would just like to summarize a couple of the concepts. Yeah.
Ahmad, were you raising your hand?
Yes, Ahmed. Actually, I just want to say that we are facing a lot of these cases that similar to what Dr. Mohammed present in Syria and Lebanon during the war, and most of them are caused by bullets and fragments. And actually, we use the same approach by using the debridement and the serial debridement and using the external fixator. And when we reach to the functional movement of the elbow, we stop because of the limited resources. Over.
Thank you, Ahmad. Yeah, I think obviously you're facing like very challenging injuries, and I think like facing them in a stepwise approach, getting an elbow stable first, then cover and assess the basically concentrically reduce and then go from there, I think is very important. So we can deal with a stiff elbow, but an unstable and painful elbow is a worse problem without soft tissue coverage. So yeah, thanks for sharing that with us. So I would like to, yeah.
Sorry, Carlos, I just want to make one last point before we close. In this case, the guy was very lucky in the sense that there was enough of a humerus and an olecranon, even though it was broken, that once it was pinned, and even if you have a bit of a fibrous union, it's still an elbow. You know, in the case where you're missing an elbow, I think I would have done exactly the same situation, but probably would have ended up bailing out to a fusion eventually. You know, like even a fibrous union, fibrous fusion, whatever, if that's functional enough. But if the patient has a lot of instability and pain, I would have just gone ahead and fused it rather than thinking about, you know, elbow arthroplasty and all that. Like at the end of the day, like having a functional, relatively functional hand, even if it's fixed in space, is still much better than being in constant pain. So that was just my thought about if there was a lot of bone loss. But incredible case, Mohammed, and I think you've really shown some remarkably well-applied principles here: external fixation, irrigation and debridement, and secondary intention as one of our best friends.
Thank you, Kiran. Yeah, so maybe I will try to, in 2 minutes, summarize a little bit of the concepts we have learned today from our esteemed faculty and case presenters. So we need to basically, in the acute scenario, deal with the trauma, basically prioritize getting a concentric elbow reduction. Either it's a fracture or it's a chronic elbow dislocation. We have to prioritize get a concentric reduction, no matter how we achieve that. Try to get the elbow as stable as possible in order to move it early and avoid elbow stiffness. But still, we need to sacrifice an error on one side. We need to err on the side of a stiff, concentric, reduced elbow. Deal with the problems in a stepwise manner. I think when we deal with a stiff elbow, don't give up early. You still have a space for improvement with reaching some range of motion if your patients are compliant, despite you having no resources for OT or physiotherapy. There's some creative solutions. Dr. Javaid mentioned about carrying a bucket to or a heavy object to increase some of the extension. And on flexion, we can have them like bending with their weight against the wall or overhead and putting some weight overhead in order to achieve some function. If we are getting somewhat late, 6 to 12 months, we have very little to gain. CPM, dynamic splinting possibly are a little bit out of reach in many settings. But we don't have to give up on the options of treating them conservatively initially. If we have an elbow that doesn't have a functional range of motion of 100 degrees, we can start considering doing open releases. And then obviously the workhorses here are as Dr. Morey described in the past, the column approach. You have it in the pre-recorded lectures and basically in the material for the course that you can review them. And also consider moving the ulnar nerve can basically be your worst enemy after doing a significant release, because it's not happy if you don't move it anteriorly, as Dr. Anderson said. So keep that in mind. And you also might have to go medially if you have an extensive elbow contractor to release the posterior bundle of the MCL. So keep that in mind as well if you're lacking of flexion. I don't know if anybody would like to add something to that, and if not, I will show you guys the link for the post session survey. Can you show it into the next slide, please? Well, thanks to everyone who attended today. We have over 100 participants most of the session. This is the QR code, so you can get your certificates after you answer the post-conference survey. Yeah, thank you everyone again to be here. We hope to see you in 2 weeks' time for the neglected pediatric elbow trauma, and then 2 weeks time after that for the gunshot and blast injuries of the elbow. We are delighted to see you all here, and hopefully you enjoy the session.
Thanks for moderating, Carlos. Fantastic job and great presentations, everybody. Thank you.
Thank you for all.
Thank you. Have a wonderful rest of the day, everyone.
Thank you.
Maya, can you just go through the last few slides?
Please remember to give us your feedback so we can improve for next conferences. Thank you.
Great job, Carlos. Thanks a lot. Sorry about my internet connection.
no problem, my friend. I knew that it was a possibility, right? We have like in the past had some issues with the connection when we are in certain areas. So
yeah.
I
All right.
will
Well, I
stop
think we can go.
Should I
Sorry,
stop
go
the
ahead.
recording? Should I stop
Yeah,
the
I think you
recording?
can probably end the meeting right there. I think that's great.